Patel. I'm one of the renal physicians at NUH. I also work at the university where I'm course director for our Masters in Medical Education. Plan over the next 25 minutes or so is to cover three aspects related to perioperative AKI or acute kidney injury, renal blood flow, perioperative AKI syndromes, and the management of fluids in AKI. We'll start with some first principles to cover the anatomy and physiology related to the glomerulus, and then move on to describing the pathophysiology of common perioperative AKI syndromes, and then we'll finish with some evidence from recent fluid trials. So let's start with a recap of GFR regulation. This is achieved through both intrinsic mechanisms, so these are those within the kidney that we specifically look at and monitor as nephrologists, and extrinsic mechanisms, so these are those external to the kidney that perhaps you guys particularly focus on, but nonetheless also have their effect on the kidney. So if we start with the goal of the intrinsic mechanisms, they are to maintain a nearly constant GFR over a wide range of mean arterial pressures, typically between 80 to 180 milligrams. For the kidney, neither too high or too low GFR is good, which is why we have these intrinsic mechanisms controlling GFR. If we imagine at high GFR, there's a risk that we filter too much blood volume and excrete it all out as urine and not actually end up with any effective circulating volume to maintain blood pressure, which is obviously a bad thing. Equally, at too low a GFR, there's a risk that the kidney isn't getting enough blood supply for itself or fulfilling its responsibility to remove waste products of metabolism, manage drugs, etc. So the two intrinsic mechanisms that we'll probably talk through for this presentation involve the myogenic response and the tubuloglomerular feedback mechanism, and both have effects that primarily act on the afferent arteriole. And we'll have a closer look at the effect of both increased sodium and chloride ions on this feedback mechanisms in a bit when we explore the effect of saline infusions on the body. The goal of the extrinsic mechanisms, on the other hand, is to maintain blood volume and blood pressure to the vital organs, the brain, the heart, and the lungs. So the extrinsic response involves neural and hormonal mechanisms mediated by neurotransmitters and hormones in the bloodstream, and these tend to get activated if there's a drop in that mean arterial pressure below 80 milligrams of mercury. In this situation, the extrinsic mechanisms are attempting to ensure adequate perfusion to the vital organs at the cost of everything else, including the kidney. The brain is essentially saying, we don't need to make urine at the moment, we just need to get blood around to the brain, the heart, and the lungs. We don't really want to urinate fluid in a fight or flight situation, which makes perfect sense, really. The sympathetic response is mediated by norepinephrine, and that primarily acts on the afferent arteriole. However, the hormonal response mediated by angiotensin II acts primarily on the efferent arteriole. And with angiotensin II, we get the secretion of ADH, aldosterone, and norepinephrine, all which lead to a retention in sodium, chloride, and water. Why? Because ultimately the aim is to increase blood pressure and blood volume. Angiotensin II also acts on the kidney to cause vasoconstriction and by and large increase GFR. And that's essentially, in broad brushstrokes, how we regulate GFR. So let's now move on to AKI and specifically perioperative AKI. I think it's fair to say over the past 2 decades, we've shifted in our understanding of what we used to call acute renal failure, but now refer to as acute kidney injury. We've specifically moved away from this sort of pseudo-anatomical classification of acute renal failure to something that better appreciates the multifactorial etiology of AKI in most cases, but also the observation that even small rises in creatinine are evidence of AKI. And this shift has fed into the way AKI is now staged and acknowledges reduction in urine output is associated with AKI, though invariably not in all instances. From this diagram, if we start towards the right of the x-axis showing GFR and work our way backwards along the x-axis towards lower levels of GFR, you can see that it's only after there's been a significant loss in GFR that there's an easy to see or notice rise in creatinine. Conversely, at higher baseline levels of creatinine, so when you've got quite significant renal impairment, so towards the top of the x-axis, even larger rises in creatinine only reflect smaller or incremental losses in GFR by comparison. And I suspect it's probably this sort of inverse relationship that's probably responsible for the delayed detection and, in some respects, response to early kidney injury. The incidence of AKI remains around 15 adults in every 1,000 hospital admission. And looking back at the reviews of acute renal failure written around the 1990s and 2000s, it's been around this number for some time. But I think in the last 24 months or so that there's been greater recognition that AKI is unlikely to be a single disease, but in fact probably more a loose collection of syndromes that are all generally characterized by a sudden decrease in GFR. So what does perioperative AKI look like through this lens then? Well, at first glance, it's probably fair to say that it's not that much different in some respects, because as you already know better than I do, the frequency of AKI among patients undergoing surgery is significantly high. There's a range from around 10% for major abdominal surgery up to about 50% for surgery such as liver transplantation or emergency aortic surgery. As shown by this diagram, you can immediately see the pathophysiology is quite complicated. There are multiple reasons for developing AKI, many of which coexist throughout the perioperative period. So coming up with a single diagnosis or insult against AKI, when you look at this backdrop, isn't really possible in some respects. Even if we use the same diagram again, but this time just look at the way in which drugs associated with AKI cause injury, you'll notice a similar thing. Drugs will also have multiple ways of causing AKI. There could be the direct toxic effect on the kidney, such as from PPIs or antibiotics, or drugs can affect the kidney indirectly through their effect on hemodynamics, either within the kidney or on the systemic circulation. Moving that forward, the main perioperative insults are listed here. Again, all of these will be familiar to you already. But with patients requiring surgery, which is why as a professional group, I think you've always advocated for preoperative assessment, it's multiple comorbidities such as CKD, diabetes, hypertension, and heart disease that will impair renal autoregulation. So those intrinsic mechanisms that I talked about, and therefore lead to chronic activation of some of those neurohumoral responses. So the sympathetic nervous system and angiotensin II mediated effects, all of which predispose to further tubular injury around the time of surgery. Patients undergoing cardiac and vascular surgery are particularly prone to these comorbidities, so by extension are exposed to the greatest risk. And it should go without saying that pre-existing CKD is both an important risk factor for post-operative mortality, but also the strongest risk factor for perioperative AKI. The most common cause of perioperative AKI is probably simply reduced renal perfusion as a direct effect of intraoperative conditions such as anesthesia, medication that causes a drop in blood pressure, or hypervolemia. And we know from that recap I gave at the start that the kidney's response to restore GFR is through angiotensin II mediated efferent arteriolar vasoconstriction triggered by that tubuloglomerular feedback mechanism, but also through prostaglandin-mediated afferent arteriolar vasodilatation. When any cause of systemic hypotension persists for a longer period of time, there'll be a more persistent reduction in that renal perfusion pressure below that autoregulatory range. So here causes may include severe hypovolemia from hemorrhage or other more insidious blood loss. But in either situation, it's that more potent vasoconstrictor response that kicks in following sympathetic nervous activation that causes increases in afferent arteriolar resistance that's the real problem. And inevitably, in these situations, there's a rapid decline in renal blood flow and therefore GFR, which, if not reversed or managed, actually leads to that irreversible tubular damage and cell death. It follows then, if patients remain on ACE inhibitors during the time of surgery, we'll see the effect of inhibiting the normal response of angiotensin II to restore GFR. If we remember from a few minutes ago, angiotensin II normally induces arterial vasoconstriction, mainly of the efferent arteriole. The reduced blood supply, blood flow through that efferent arteriole raises hydrostatic glomerular capillary pressure and helps maintain GFR. But without that effect of angiotensin II on that efferent arteriole, because of the use of ACE inhibitors or ARBs, the tone of that vessel is slightly relaxed. The hydrostatic pressure will try to remain the same, but inevitably will drop, and the kidney can't protect itself through that intrinsic system. So GFR ultimately drops and risks tubular damage. The impact of non-steroidals on the kidney are multiple. However, in the context of renal blood flow in the perioperative period, the effect is a drop in GFR because you lose the effect of those vasodilatory prostaglandins. And unlike in scenario 1 a few slides ago, there's now unopposed constriction of that efferent arteriole and a greater, almost enhanced angiotensin II effect on the efferent arteriole, both of which drop GFR. And finally, patients who suffer with chronic hypertension, they develop arteriolosclerosis over time. So there's less blood flow getting into those vessels, into the glomeruli, and causing ischemia. So how does all of this actually impact on fluid therapy in AKI? So far we've talked about the anatomy and physiology in theory, but where's the evidence that any of this has any clinical relevance when it comes to management of AKI or fluid prescription, basically the infusion of intravenous fluids? Well, this figure attempts to represent where fluid we prescribe will redistribute after infusion. Much of the fluid we give won't actually remain in the vascular space, despite that intention during volume resuscitation. Instead, much of it ends up in the interstitial space, especially the more we give. This table neatly illustrates the breakdown of those different fluids by electrolyte composition and osmolarity. Immediately, if you look in the second and fourth columns, sodium and chloride, you can see that the concentrations of those across the different fluid varies, as does the osmolarity between the different solutions. And the osmolarity, so the number of solutes that are osmotically active per litre of solution, is important because although the vessel walls are impermeable to these ions, water will still move freely across these body compartments. Depending on the composition of that infused fluid, there may actually be large shifts in and out of those cells. This matters because there's been some suggestion, supported by some published studies, that the type of fluid used in resuscitation may paradoxically worsen renal injury, in particular 0.9% saline. The hypothesis is that there's significantly more chloride in 0.9% saline compared to other intravenous fluids, that and it's the increased concentration that may be causing problems at a cellular level. This was the first study that I could find conducted in the ICU of a university-affiliated hospital in Melbourne almost a decade ago. And it was the one that probably got people looking into this problem more so than previously. All patients received 0.9% saline as the resuscitation fluid of choice, followed by a 6-month phase-out period, and then 6 months of a balanced solution, either Hartmann's Plasma-Lite 148 or Chloride Poor albumin. The authors reported there was a significant reduction in the incidence of AKI and need for renal replacement therapy amongst patients who received balanced fluids. Now, it wasn't a randomized study by any stretch of imagination, so possibly that you've got the Hawthorne effect and other biases. And there was also, there wasn't a significant impact on other outcomes, secondary outcomes, if you may, ICU stay or mortality in, that we might also look at. But nonetheless, let's zoom in now and actually see how fluids with high chloride concentrations might affect the kidney. And no need to feel that you need to read anything on the slide, except to say that the takeaway point I want you to see from this research was that experimentally infusing high chloride containing fluids into animal models was found to decrease renal perfusion and GFR. Okay, but that's animal models. What about humans, and why does that matter? Now, in this local study actually conducted here at Nottingham, 12 healthy adult male subjects received 2-litre infusions over about an hour of 0.9% saline or Plasma-Lite 148 in a randomized double-blind manner. It was a crossover study, so a switch happened 7 to 10 days apart. MRI scanning proceeded for about 90 minutes after starting the infusion to measure renal artery blood flow, velocity, and perfusion. And so the findings did end up showing that this was the first human study to demonstrate intravenous infusion of 0.9% saline resulted in hyperchloremia, a greater expansion of that extravascular space, even though measured blood volume changes between the two groups were similar. And there were also more significant reductions in renal blood flow velocity and renal cortical tissue perfusion amongst those who received 0.9% saline. The question we need to answer is, why does high serum chloride decrease renal blood flow and GFR? And the answer is likely to involve the macula densa. So these are specialized cells in the kidney that sense sodium and chloride levels in the distal convoluted tubule. And in response to increased sodium and chloride levels in the distal convoluted tubule, their activation leads to a decrease in renal blood flow and GFR through afferent arteriolar vasoconstriction. And they do this through various intracellular mechanisms, which I'll show you. Firstly, in this image, notice how close those cells are to the renal afferent arteriole. And when you expose these cells to high levels of chloride and sodium, as shown in the right-hand image, i.e. a large bolus of intravenous fluid that has been infused, those macula densa cells literally swell up. And both sodium and chloride enters these cells through various channels, and water simply follows in. Now, in response to that swelling, these macula densa cells release ATP, causing calcium release from the smooth endoplasmic reticulum, which binds to the vascular smooth muscle cells and causes vasoconstriction of the afferent arteriole. This causes a release of calcium, and this stimulates renin from nearby juxtaglomerular cells, and ultimately the production of angiotensin II again, the net effect being even more reduced renal blood flow and GFR. So now it's not just the movement of sodium that I think people are realizing is harmful, but now we think it's chloride into these macula densa cells, and that causes ATP release, which in turn signals to the afferent renal arterioles to constrict and cause the GFR to fall. And now we know that there's a plausible scientific explanation for the less than desirable effects of 0.9% saline on the kidney. Do the patient outcomes in recent fluid trials in AKI actually back up this hypothesis? So SPLIT, some of you may be familiar with, was a prospective multi-center randomized double-blind crossover study. The ICUs changed their protocols every 7 weeks from either saline as their base fluid to plasma-like 148, obviously blinded from knowing which one they were using at the time. Patients included were those who required crystalloid therapy in an ICU setting, except those who were either expected to require dialysis anyway within 6 hours, they weren't included, or patients who were already on dialysis, they weren't included, or anyone admitted to an ICU for palliative or organ donation care, they weren't included. Patients were followed to hospital discharge, death, or a 90-day censoring point, and the primary outcome in this study was development of AKI using predefined criteria. Secondary outcomes included any creatinine change, need for dialysis, mechanical ventilation, length of stay, and all-cause mortality. And in summary, they found little difference between the two regimens. So the incidence of AKI, renal replacement therapy, or all-cause mortality was not statistically significant. So this study didn't really answer the question of whether we should or shouldn't be using saline either way. What it potentially did was say that it may not be harmful. These next two studies published in the New England Journal of Medicine were both single-center, pragmatic, unblinded, cluster randomized multi-crossover studies, so bi-month interventional trials. One was called SALT-ED and the other was called SMART. SALT-ED enrolled patients in the emergency department, and basically patients were eligible if they'd received at least 500 mils of crystalloid and were then going to be admitted into hospital rather than just discharged from the emergency department. The trial period ran over 16 months, so alternating cycles of saline and balanced crystalloids. SMART, however, included all patients admitted to any of 5 intensive care units over a varying period of time, again, alternating months of saline and balanced crystalloids. The pragmatic aspect of both of these trials referred to the fact that inclusion and exclusion criteria weren't that detailed. Basically, all patients got included into both trials unless they'd either received less than 500 mils of crystalloid or were sent home. And you can decide whether 500 mils reflects what we normally give as part of volume resuscitation. And we'll look at the volume infused as well in a minute. In SALT-ED, so this is the emergency department study, the primary outcome was hospital free days to day 28, which in itself works out to be a composite of hospital death or hospital length of stay. There were 3 key secondary outcomes, what they defined as major adverse kidney events, MAKE, if you within 30 days, and this was a composite of death, new requirement for dialysis, or persistent kidney dysfunction, which they defined as a final serum creatinine that was greater than 20% of baseline. In SMART, which was the ICU study, the primary outcome was major adverse kidney outcome events at hospital discharge or 30 days, whichever came first. And they define them in pretty much the same way. There was various secondary outcomes, obviously more appropriate to a ICU context. So ventilator-free days, vasopressor free days, days alive, and days free of renal dialysis within 30 days. The findings from SALT-ED that showed for the primary outcome, hospital 3 days, there was no significant difference between the two groups. However, for the secondary outcome of major adverse kidney events, so death, new RRT, or persistently raised serum creatinine, there was a statistically significant difference between those who received balanced solutions. Likewise, from SMART, they also showed that for their primary composite outcome, which it was the same as, you could argue, the secondary outcome from SALT-ED, some major adverse kidney events, these were also lower, so deaths and new dialysis, for those who received the balanced solution. So what does this all mean? Should we be switching or advocating more use of balanced solutions? Well, I think there's a small cost difference of a few pennies, perhaps, but at least there's no signal that the balanced solutions are any worse than the 0.9% saline. And if anything, the results from these studies would suggest that they improve kidney outcomes. There are ongoing randomized and blinded trials still recruiting. So there's the PLUS trial, which is looking at higher risk patients, which reflect more of those who I would argue reflect those in the context of perioperative AKI who sustain the worst outcomes. So there's currently a study in Australia and New Zealand that's looking to recruit over 8,000 patients. The last primary outcome participant is meant to be recruited in this last quarter, and the publication of those results will be available in the second quarter of 2021. And there's another large fluid trial which aims to recruit over 65,000 patients, again using a cluster randomized control design in Canada. Before we wrap up, it's probably worth mentioning the role of bicarbonate fluid in the management of severe acidemia in AKI. Bicar ICU is an open-label, multi-center RCT in ICU patients with a pH of less than 7.2 and a bicarb of less than 20. The control group received no bicarbonate, and 194 patients were recruited into that arm. The intervention group received 4.2%, so the lower bicarb concentration, more like what we can find on the wards, to maintain a pH of greater than 7.3, and 195 participants were recruited into that arm. The primary outcome in that study was time to death, and secondary outcome was stated as reduced mortality observed in those with AKI stages 2 and 3. The results from this trial are shown on this infographic. Again, they confirm that patients with severe metabolic acidemia, sodium bicarbonate, may not have had any effect on the primary composite outcome, but then when you split it down into those who required dialysis and or look at severity of AKI, those who did receive the bicarb, there was a statistical difference between the two groups of better outcomes for those who received the bicarb. So I think, to summarize really, renal blood flow and autoregulation is complicated, but the intrinsic mechanism is there to and essential really for maintaining GFR between mean arterial pressure ranges of around 80 to 180. Perioperative AKI is complicated and likely caused by the effect of the extrinsic systems overriding those intrinsic ones when the mean arterial pressure is less than 80 for whatever reason, but usually hypervolemia or drugs. And I think there's a growing body of evidence that fluid choice, especially the use of 0.9% saline in AKI, is associated with adverse outcomes. Thank you.